Hello, this is Dr. Juan Garcia. This video will only focus on the no-touch subacromial injection technique. Other shoulder injections will be addressed in other videos. Subacromial injections are useful as a therapeutic measure and also as a diagnostic tool, as is the case of the lidocaine impingement test. Corticosteroid subacromial injections are usually performed after conservative treatment has been attempted. In some acute conditions, such as acute subacromial bursitis, they could be used as initial treatment. Before attempting the procedure, review the risks, benefits, and alternatives with the patient. Review the contraindications, clearly explain the procedure to the patient, and obtain informed written consent. Subacromial corticosteroid injections are indicated for a range of conditions such as calcific tendinitis, rotator cuff tendinosis, impingement syndrome, subacromial subdeltoid bursitis, and adhesive capsulitis. Isolated rotator cuff tears are not an indication for this injection. The equipment needed includes the steroid solution, in this case methylprednisolone, 1% lidocaine, skin cleansing agent pads, alcohol pads, a 1.5-inch 18-gauge needle for loading the medication, a 1.5-inch 22-gauge needle for performing the procedure, a 10 cc sterile syringe, procedure gloves, and a bandage. Prepare the injection mixing 5 to 9 cc's of 1% lidocaine and 40 milligrams of methylprednisolone. After that, change the needle to deliver the medication. First, identify the acromioclavicular joint. If it is difficult to find it, just follow the clavicle border until you are able to palpate it. First, find the AC joint. Then, find the posterolateral corner of the acromion. The point of the needle insertion is 2 to 3 centimeters inferior to it. Point of needle insertion. Establish the anatomical landmarks and mark the injection site with close end of sterile needle cap. Clean the area with antiseptic solution twice in an outward spiral motion. Then, dab it with alcohol. Without touching the sterile area of the skin, insert the needle at the previously explained point of insertion. Aim towards the AC joint and draw back on plunger to ensure no blood vessel has been entered. Administer the injection slowly to avoid discomfort. Maintain consistent pressure. The solution should flow easily without significant resistance. Always maintain a sterile technique during the procedure and keep holding the syringe in a correct position. When done, withdraw the needle rapidly and apply pressure on site. Then, cover with a bandage. Complications of corticosteroid injections include tendon rupture, post-injection steroid flare, septic arthritis, subcutaneous fat atrophy, skin depigmentation, soft tissue calcification, synovitis, bleeding and bruising, blood vessel and nerve damage, facial flushing, anaphylaxis, needle fracture, syncope, and systemic effects. Contraindications for the procedure include skin breakdown and skin infection at the injection site, bacteremia and sepsis, known hypersensitivity to the medications, uncontrolled coagulopathy, anticoagulation treatment, and joint prosthesis. Diabetic patients should be warned that blood sugar levels could rise for a few days after the injection. Keep in mind that caution is advised in patients on anticoagulation management. After the injection is administered, advise the patient to avoid major weight lifting involving the injected shoulder for 7 to 10 days. If symptoms of steroid flare appear, the patient could use local ice packing and over-the-counter analgesia. Schedule a follow-up visit 3 weeks after the procedure.